Okay. So we're just going to be kind of flipping back and forth through them. So really kind of just 3 large topics and then kind of some practice questions to go through them. This is going to be, I think, a second time around for this topic, right, for most people in here. So trying to move through some of the foundational content a little bit quicker. That way we have time to kind of discuss common questions or the way they ask the topics. So let's shoot for pituitary, adrenal, and diabetes today if we can get through all of those. So in terms of pituitary, the anterior pituitary, and you'll see on this slide here, right, again, kind of breaks down what is secreted from anterior versus posterior pituitary. Everybody is there? So this is in the actual book. What page? Does somebody have the page? 17. Page 17. So in terms of this, right, the anterior pituitary secretes 6 things: growth hormone, ACTH, TSH, prolactin, FSH, and LH. For those of you that don't have your books, right, these are some things that you could also start filling in on that question sheet. So being mindful of how these are regulated, right? So these are regulated from the hypothalamus, all of them usually in a positive manner, with the exception of prolactin here, right, which is under inhibition, right? So in normal state, dopamine is released to keep prolactin under kind of tonic inhibition. So if you have something that affects the stalk, right, or this communication from hypothalamus to pituitary, you see deficiencies of most, but you can see high prolactin just because of that stalk disruption. You lose that tonic inhibition. So talking first about situations of excess, right? So these are the different presentations of hormone excess from the pituitary. So acromegaly is growth hormone excess. Cushing's disease is Cushing's syndrome from ACTH excess. Central hyperthyroidism, which is very rare, is from excess TRH, leading to TSH. And then prolactinomas. So prolactinomas are the most common functional pituitary adenoma. On the test, they are going to want you to not assume that every prolactin elevation is due to a prolactinoma, right? Looking at their medications, are they on metoclopramide? Are they on antipsychotics? So kind of being mindful of the conditions that can increase your prolactin level, which those are right here, before you are saying that this prolactin elevation is from a prolactinoma. So in terms of going into each one of these in detail, right, and you can even start filling out this chart on the bottom of this question page as we kind of go through them. So what symptoms do you get from a prolactinoma? Galactorrhea. Headache. What did you say? Pie in the sky? Oh, yes. Right, so pretty much that is more mass effect as opposed to discretely from a prolactinoma, the heminopsia. Amenorrhea, and the amenorrhea is caused by actually more of a suppression of FSH and LH, right, kind of the prolactin going back and inhibiting FSH and LH production. And you can have some hirsutism. So evaluation-wise for a prolactinoma, you're going to be getting a prolactin level, and then you're going to be getting an MRI of the brain. There is some correlation between prolactin level and pituitary adenoma size, right? right? So if you see a very large macroadenoma, like 2 centimeters, and the prolactin level is just barely elevated, don't assume that just because the prolactin level is, I don't even know what barely elevated is, 40, what have you, that you're saying that that is from this huge pituitary tumor, right? I would then be going back and saying, what meds are they on? Are they also on a medication that can increase that prolactin? And then evaluation-wise, and then treatment. So how do you treat a prolactinoma? Right, dopamine agonist. So star that box on your answer sheet. This is the one the one pituitary adenoma that you are not sending to surgery first. Even if they have mass effect, if they're pregnant, visual changes, anything like that, you are going to be starting with these medications because they work very fast and they're very effective. I don't think that they would make you choose between the two on the test. We often use cabergoline because it's less times per week that they have to take the medication. So I don't think they would have both of those answers and have you pick one or the other. So next on your chart is Cushing's disease, right, which is Cushing's syndrome from a pituitary adenoma. So your symptoms are going to be very similar to Cushing's disease, really of all causes, with the little caveat of some extra hirsutism in patients with Cushing's syndrome from a pituitary adenoma. And so we'll talk about that a little bit in the adrenal section, right? But this ACTH that you have very elevated, causing your cortisol to be very elevated, also acts on the GFR, right? So the zona reticulosa in the adrenal gland, the part that produces DHEA, or the androgens, right? Does that make sense? Whereas if your cortisol excess was purely coming just from the adrenal gland, you don't have that extra ACTH also stimulating that DHEA, right? So we are going to be talking about evaluation of Cushing's syndrome more in the adrenal section, but really kind of three main tests that you use to screen. You have the 24-hour urine-free cortisol, you have the low-dose 1 milligram dexamethasone suppression test, and then you have the 11 p.m. salivary gland cortisol. So pretty much everything in endocrinology, we're going to be talking about confirming hormonal imbalances biochemically first. Once you have confirmed that, then doing more localization and imaging. So usually if you have one screening test that's positive, you would screen again before you move on to the next step, just because of the chance of false positives, right? So you would screen technically twice, but if the first screening test is negative, you would say you do not have Cushing's. But if they're screen positive, you screen again, and then your next step, if you're for Cushing's disease, you would expect the ACTH, which is kind of your next localization step, to be high, right? Because that's your problem. Your cortisol is high because your ACTH is high. And then that would direct you to the MRI of the pituitary, right? Whereas if your ACTH is low, you're going to be looking at other sources for that cortisol excess, right? You're going to be focusing towards the adrenal gland. Treatment for Cushing's disease, right? Cushing's from the pituitary adenoma is surgery, right? Surgery, except for the prolactinomas. There's some stuff that you can use for kind of residual cortisol excess even after surgery. These are more kind of adrenal ablative therapies. I don't think they would ask you too much about those. The next one is acromegaly, right? So here's some signs or symptoms of acromegaly: the frontal bossing, the enlargement of the jaw, the teeth getting spaced out, skin tags, colon polyps, enlargement of the tongue, enlargement of the hands and spade-shaped hands. So your first screening test for acromegaly is IGF-1, right? So they like to ask this question because they're trying to catch people who think acromegaly is from growth hormone excess, so let me test growth hormone. But the problem with that is growth hormone is it's also pulsatile, it's more erratic, it's hard to have a defined measurement in time. So you're checking a byproduct of that growth hormone. So if your growth hormone is high, your IGF-1 should be high. And then same thing in the deficiency, right? On the other side for hypopit, you're also doing an IGF-1 and seeing that being low for low growth hormone. So I would highlight or star this because that's a common question or a common trap that they're trying to catch people in. So that's your screening test. Your confirmatory test is going to be a glucose tolerance test where the growth hormone fails to suppress. Treatment, surgery, right? Because this is not a prolactinoma, so your treatment is surgery. Again, there's some other therapies that you can use if there's residual disease and residual tumor. Your IGF-1 is not kind of within the normal range after treatment. So there's some somatostatin analogs, radiation therapy, things like that. But knowing that surgery is first line is key. Central hyperthyroidism is very rare. The way that they like to ask this on the test is giving you somebody who looks like overt hyperthyroidism and interpreting the labs. Because looking at just the labs, you're like, oh, it's kind of normal or not as bad as I was expecting. Your TSH for hyperthyroidism from the thyroid is going to be what? Right? Super low, less than 0.001. But your TSH with central causes could be high, could be high normal. So kind of keep that in mind. So if you see something that looks a little wonky, right, especially with that TSH, that's opposite of the clinical picture because this is so rare, we don't see it too much. Make sure you don't just brush by looking at just the thyroid hormone levels being high, because those are both going to be high in both scenarios. So make sure you pay attention to the TSH. Let's talk about pituitary adenomas in general. So let me flip to this document. So we said disruption of the stalk decreases all pituitary hormone secretion except prolactin. That will increase because you've lost inhibition. What infiltrative diseases can cause issues in the hypothalamus and or pituitary? Sarcoid, hemochromatosis, histiocytosis, Langerhans cell. You can have metastatic disease to that region, and lymphomas. The hormones that are released by the posterior pituitary are ADH and oxytocin. The one that you will get tested on the boards is ADH. So you'll talk a little bit more about that in the nephrology section. So just a brief little question here. A 20-year-old patient has headaches, decreased urine osmoles, which means his urine is concentrated or dilute? All right, so dilute, right, his perhaps around 100, like you would see with primary polydipsia. Elevated prolactin. Why do they have an elevated prolactin? and decreased osmoles. What could tie those two things together? Something with the stalk, right? So something where you're having loss here of the stimulus for ADH, and then you're blocking the inhibition of prolactin, right? This CT shows dense supracellular calcifications. What is that a buzzword for? Craniopharyngioma, right? So this is going to be classic, a young patient coming in with, what do they have? Diabetes insipidus, right? That's why their urine is so dilute. You could expect that if they had told you, what would their sodium be? In a normal state, what would their sodium be? Their everyday walking around state. It could be normal, right? They could be peeing liters and liters a day, but as long as they're carrying around, their jug of water that they're refilling all day, they can keep their sodium in range for the most part, right? But sometimes this comes up in a patient with this, or a patient with diabetes insipidus from lithium, and they come into the hospital and they're made NPO, and then their sodium jumps 10, 15 points overnight, right? Because you've restricted their access to water, right? And their thirst mechanism, you're physically blocking what's keeping their sodium in range. So talking about the different presentations of pituitary adenomas, right? So 4 main things to think about. So we already talked about the secretory function, right? So what are the 4 syndromes that you can get from secretory function? Cushing's, hyperthyroidism, acromegaly, and prolactinoma. There's not a fun syndrome name for that, but the other thing to think about is mass effect, right? Because if you have increased secretory function, you need to do treatment, right? If you have symptoms of mass effect, you need to do treatment. If there's hemorrhage, you need to do treatment. If it's an asymptomatic incidentalloma, that's non-functional and not exerting mass effect, right? Just monitor. So what symptoms of mass effect could they have? Bitemporal hemianopsia, headaches. The other big one to think about and remember is hypopit, right? This tumor could get so large that it's kind of suppressing the other portions of the pituitary gland to have appropriate function, or it's blocking the ability to get those hormones from the hypothalamus. So you can have hypopituitary from a pituitary adenoma. You can have hypopituitarism from treatment from a pituitary adenoma. So a lot of these can have really presentations across the spectrum, right, of hyper and hypofunction. Hemorrhage into a pituitary gland we call apoplexy, right? Pituitary tumor apoplexy. How will they present?
After pregnancy?
So this could be, right, the risk factors are somebody with a known pituitary adenoma, or on the test they'll give you somebody on blood thinners who perhaps doesn't know that they have a pituitary adenoma, and they're bleeding into their gland. They actually present kind of similar to a meningitis. They're going to have acute onset of headache, neck stiffness. They can have double vision. So on the CAT scan, you can pick this up, but you have to really have a high index of suspicion when somebody's coming in kind of with an acute, severe headache, right? So you might be doing it for subarachnoid and then really kind of catching this. You can also have symptoms of acute hypopit, right, from this hemorrhage, which the most severe manifestation would be, right, adrenal insufficiency, a central cause of the adrenal insufficiency. How do you treat pituitary tumor apoplexy? Steroids, neurosurgery consult to evaluate for decompression. All right, so those are going to be your two urgent interventions for this condition. And then an asymptomatic incidentaloma, you want to assess for mass effect, you want to screen for secretory function, and if those are negative, you can monitor clinically and observe. Right? So a patient on Coumadin presents with sudden onset of headache, stiff neck, double vision, shock. We talked about the next step in treatment, right? Neurosurgery, eval, and steroids. The medications that can increase prolactin levels. Antipsychotics. Probably SSRIs. I think not as common as antipsychotics. So antipsychotics, metoclopramide or Reglan, and marijuana are going to be the ones that they like to test about on the exam. What is your first step in the evaluation of a high prolactin level? Before that? Pregnancy test.
For the back to steroid dosage, are we using like the hydrocortisone or dexamethasone? Does that matter?
I think either would be fine, but Decadron, I would say, would be more like cerebral edema or vasogenic edema, whereas this is more for the functional adrenal insufficiency. So I think hydrocortisone at stress doses,
Okay.
I think would be fine. I don't think they would have the two answers
But those, they wouldn't
against
put
each
those
other,
in.
no. So your first line therapy for almost all pituitary macroadenomas or hypersecretory adenomas is surgery. A patient with a prolactinoma who is on dopamine agonists becomes pregnant. What do you do? I guess you would need more information. But let's say she initially came in with amenorrhea and was trying to have kids, and it was found that she had this prolactinoma that was a microadenoma, right? So we're not talking about a macroadenoma causing mass effect when she was diagnosed. So she was started on cabergoline and then becomes pregnant.
Don't you expect it to get bigger?
So you can have consult endocrine. So you would stop it. Your purpose of adding it at this stage was to help the amenorrhea, to help her get pregnant, right?
You check for visual field.
So you need to follow symptoms and visual field testing. Because can you check a prolactin level in her during pregnancy? No, right? So you are not going to be following prolactin levels during pregnancy. The next one, this one I don't think will be on the test since it's like a third line agent. It's very expensive, but this is a newer therapy out there that you can use after surgery in patients with acromegaly. It's in the book. It is pegvisomant. don't think they would ask you necessarily something so fancy, but this is kind of some newer therapies out there that can help control residual disease. In your patient who has galactorrhea, you did workup, you checked prolactin levels, TSH. The TSH was normal, the prolactin levels elevated. The pregnancy test is negative. What is your next step?
Ask her about her recreational drug use.
Correct. She takes no medications at all. So she doesn't have a medication reason to have this prolactin elevation. What is your next step? MRI, right? MRI of the pituitary. A patient has a microadenoma. The prolactin levels increased, but not too high. She has amenorrhea and wants to get pregnant.
So is this the same thing where you just monitor?
Final answers? Right, giving her therapy, right? So starting a dopamine agonist. You are also going to be doing what else? Checking a TSH, right? Presumably you have a TSH at this point. You already have your MRI of the brain showing the microadenoma. So you are going to be starting therapy to fix this amenorrhea so she can conceive.
Is there a difference between the two as far as like pregnancy safety? Do they make you go between those two?
I don't think they would make you choose. Bromocriptine has, I think, more data since it's older, but I don't think they would have you pick between the two. And if you did, I would say bromocriptine because it would have more data. A patient presents with vision loss and headaches. The MRI has a 1.4 centimeter adenoma, has impingement on the optic chiasm. The prolactin is over 1,000. The cortisol is low, testosterone is low, free T4 is low. What does this person need? So not surgery. This is a prolactinoma. Prolactinomas we treat with not surgery. You're going to treat meds first. Dopamine agonist. What else does this person have? Bless you. They have hypopit, right? From their pituitary adenomas, mass effect. So what else do you need to give them? Steroids. Maybe some testosterone if it's really bothering them. And levothyroxine, right? My priority would be the dopamine agonist, the steroids, the synthroid. Then we can talk about the testosterone. But fixing the prolactinoma will fix that problem, and then they would not need the testosterone, right? A patient with constipation, cold intolerance, amenorrhea, and galactorrhea. The prolactin levels mildly elevated. We'll say 50. The MRI has some pituitary fullness. What is your next test? Yes. Why a TSH? Right, because they're giving you some symptoms of hypothyroidism that would not be explained by a prolactinoma. You are seeing visual changes on the MRI of this fullness, but the prolactin level's really not that high. So you should be thinking, is this prolactin elevation really from hypothyroidism? Hypothyroidism causes your TSH to be hypothyroidism from here, causes your TSH to be high, which that can also actually feed back and cause that hyperplasia in the pituitary gland, making it look full. A patient has tachycardia, tremor, weight loss. TSH is normal. Hormone levels are high. Radioactive iodine uptake scan shows increased activity in a homogeneous distribution. What is your next step in management? Right, you're a little biased because we're in the pituitary section. Is this what you would expect? It is inappropriately normal, which means it is too high for this patient. Should this patient have even had an uptake scan? No. Right? So you should have started with an MRI of the pituitary. This uptake scan is trying to lead you to Graves, but it's just increased uptake because it's getting all of that stimulation or stimulus from the pituitary. So for central causes, they are can give you a TSH that is normal, but on the other end that you would expect, right? You would expect this person's TSH to be closer to 0.1, not closer to the 3-4 range. And it's going to be the same thing for central hypothyroidism. So flipping back and talking about hypopit, right? So issues in the pituitary gland here leading to decreased hormone secretion. So we talked about causes like a pituitary adenoma exerting mass effect, brain injury, somebody who's had neurosurgery, brain radiation. We've talked about the infiltrative diseases that can affect the pituitary or the stimulus from the hypothalamus. Right, so really a lot of the same etiologies here with the added fun of the craniopharyngioma. There's vascular diseases, right? So we talked about acute apoplexy causing acute hypopit. You can have ischemia or infarction. We usually see that classically on the test as Sheehan's, right, or a postpartum blood loss leading to pituitary ischemia. There's metabolic causes. Again, this is more infiltrative. So the symptoms are really related to the deficient hormone and thinking about these in priority range, right? I don't think they're going to give you anybody with an isolated growth hormone deficiency on the test and ask you if you want to give, growth hormone therapy. But you're going to have this maybe in combination with some of the others. So central adrenal insufficiency, right? So you have loss of ACTH, which leads to loss of cortisol. So how does this look different from Addison's, right? So this is one of the ones where the two presentations are very different. Whereas central hypothyroidism, whether it's hypothyroidism from here or hypothyroidism from here, they're going to look the same. So central adrenal insufficiency is different. They're going to have some nausea, vomiting, fatigue, kind of vague symptoms. They're not going to have as much hypotension as Addison's or primary adrenal insufficiency because they still have aldosterone axis working over here because their adrenal gland is fine. Does that make sense? So they're not going to have as much hypotension. They're not going to have the hyperkalemia because their aldosterone, renin-aldosterone axis is intact. This is unique. They will have loss of axillary and groin hair, right? Loss of ACTH equals decreased DHEA from the adrenal gland. Just like on the flip side with Cushing's, you get hirsutism from the increased ACTH. this is a clue for central adrenal insufficiency. So the test of choice is a little bit trickier. You can do the cosentropin stim test, right, where you check an 8 a.m. cortisol, you give cosentropin or ACTH, and then you check another cortisol in 30 minutes, 60 minutes. You would expect it to increase to over 18, 20-ish, or at least go up by 10 points. But you need to interpret that with a grain of salt with these individuals, depending on when the adrenal insufficiency here happened. If it's acute, then their adrenal gland is fine, and they'll still be able to respond to that ACTH, right? If this was from Sheehan's 6 months ago, and now they're kind of coming in with these vague symptoms, and it's been 6 months since the adrenal glands have had some ACTH, they may also have some atrophy now, so they may not respond as well. Right? You might see a little bump or increase in that cortisol, but this test could be normal in somebody who has an acute problem causing their central adrenal insufficiency. The ACTH here is going to be low or inappropriately normal. And then treatment-wise, treatment for this is going to be hydrocortisone, right? Usually 2/3 dose in the morning, 1/3 at night, right? So maybe 20 and 10. Do they need Florinef? No, right? Because their adrenal gland is fine, and aldosterone is still being maintained because it's under the renin-angiotensin system. So they only need the hydrocortisone. Any questions about that? So for central hypothyroidism, so I would say clues or testing, common testing features for this is picking up on the difference in presentation from Addison's or a primary adrenal insufficiency, and not treating them with Florinef because they don't need it. For central hypothyroidism, the symptoms are going to be just typical for hypothyroidism, like a Hashimoto's. Your clue is going to be the TSH is going to be inappropriately normal or low, right? So if you have somebody coming in with constipation, cold intolerance, hair changes, weight gain, and you're like, oh my gosh, this person looks hypothyroid, let me check a TSH. The TSH comes back as 1.2. Oh, no. I guess I was wrong. They're fine. It's just being a middle-aged lady. I don't know. But you need to have a high index of suspicion and then checking that free T4 still. Does that make sense? So you want to be checking that free T4 really as your marker in diagnosis and in management. So I would highlight or star this. You are not going to be adjusting their therapy based on their TSH. It is not going to change. That is the problem. The problem is their TSH. So you are going to be adjusting their Synthroid based on their free T4 levels. So this is totally different from all of the other patients that we manage with hypothyroidism from Hashimoto's or iatrogenic from resection. So they love to ask that question to see who's going to be following this patient with the TSH in 6 to 8 weeks to see if it changes. We're going to be talking about hypogonadism tomorrow, so we're going to skip this for now, and let's head back over to our question sheet. So for hypopit, we talked about central hypothyroidism. The symptoms are going to be classic, right? Evaluation is going to be TSH, and if you think, right, maybe they have a reason to have hypopit, add on a free T4 off the get-go, right? Treatment is going to be the same, right? Levothyroxine, but your follow-up is going to be different, free T4. central adrenal insufficiency. The symptoms are going to be muted, no hyperkalemia, no hyperpigmentation, with the added symptom of loss of axillary and groin hair. Your evaluation is going to be stim test with grain of salt, an interpretation, and ACTH. Your treatment is going to be hydrocortisone only, not fludrocortisone. Hypogonadism we'll talk about tomorrow. And then growth hormone deficiency. I don't think they're really going to be asking you to do treatment or things of that nature. A third trimester patient has a history of vitiligo. When you see this on the test, that means other autoimmune conditions are coming, right? They present with headache, nausea, vomiting, fatigue, hypotension. This sounds like what? Adrenal insufficiency. Tie that into a third trimester pregnant patient and you think of this condition. Nope. She has not delivered yet. She still has baby. An autoimmune pituitary condition that affects third trimester pregnant ladies. Lymphocytic hypophysitis. I would say, right, since we're speaking of hypophysitis causing hypopit, classically, what medications are they going to have on your test that cause hypophysitis? Immunotherapies, like all of your patients at Moffitt with ipilimumabs, right? All of them are at risk for an autoimmune hypophysitis from those immunotherapies. So this is a lymphocytic hypophysitis, and what sort of treatment does she get right now? Right, you are going to be giving her some hydrocortisone, plus assessing for other loss of function, right? Does she also have a central hypothyroidism? All of that you can kind of flesh out on a non-immediate basis. A patient has prior neurosurgery and irradiation for a pituitary adenoma. This means you need to think about central hypopit issues, right? Coming in with constipation, dry skin, fatigue, and weight gain. She is already on hydrocortisone and levothyroxine, right? Sometimes these questions jump the gun and you're like, that's what I thought you were going to ask me to do, right? So she's already on the replacement therapy for hypopit. So what is your next test? What's going on? Free T4, right? So you're saying her hypothyroidism does not sound controlled. I need to probably adjust her dose of levothyroxine. I'm going to check a free T4 and not a TSH in her. A patient has decreased libido, erectile dysfunction, a low testosterone level that you would also recheck and make sure that this is in the morning, which we will talk about tomorrow. The prolactin level was increased. FSH and LH are decreased. How could you treat his hypogonadism? What does the low FSH and LH tell you? You always have to take a minute with all of these questions on the test and say, where's my problem? Which gland is it? Right? And does it make sense the way I'm thinking? Right? So if the problem was in the testicle, he would have low testosterone because the problem's the testicle. So then his pituitary would say, I need more testosterone, and will increase more FSH and LH. right? So now you know that the problem is here in the pituitary, not making the FSH and LH, and that is why you do not have the testosterone, right? So you already know I'm going to be looking here. You would do probably some labs, right? The transferrin saturation, right? You would do a prolactin. You could get an MRI of the brain, all sorts of fun stuff. Rule out OSA. But they're giving you a clue, right, that there's already one of those things that can feed back and decrease the FSH and LH. Just like in ladies with prolactinomas getting amenorrhea because of low FSH and LH, men can get hypogonadism. So you would treat this guy with testosterone or cabergoline. Cabergoline. The trap is going to be saying, I will fix his testosterone deficiency with testosterone. A patient with amenorrhea and failure to lactate after giving birth 6 months ago. She has fatigue, constipation, dry skin. She has a low free T4 and a low normal TSH. What is your next step?
Oh, just.
Because they're both.
Why cortisol?
Well, checking the T3, you have an answer.
Correct. When is the only time you should be checking a T3? Thyrotoxicosis. That is the only time. So you're left between treating her central hypothyroidism or screening for something more serious, that giving some synthroid and enhancing her metabolism might make worse, right? So they are both correct. Which one should you do first? C, right? So A was the trap. What's the most common cause of central adrenal insufficiency? From? Right. You taking steroids, right, tells your pituitary gland, I don't need that ACTH. I have steroids in my body. So then you lose that ACTH production, and that's the most common cause of central adrenal insufficiency. This medication is used for appetite stimulation and has some steroid activity. So you can also have ACTH suppression occur. And if they stop this medication, you can have symptoms of adrenal insufficiency. Megase. So, one page done. The adrenal gland. So again, you have a little bit of a chart to fill out here as we are discussing the structure and anatomy of the adrenal gland. Right, so you have the cortex, which is GFR, and then in the middle is the medulla. The deeper you go, the sweeter it gets. Yes. That is all the way back from med school.
Shouldn't sweet be the central one then?
That's so sweet. So you have your mineralocorticoid, right? This is your salt. Cortisol is your sweet. DHEA is your sex hormone. Remembering what stimulates them, right? So aldosterone from renin-angiotensin, cortisol and DHEA from ACTH. That's why with central causes, with your ACTH being high or low, you affect both of those. So talking first about excess again, right? So excess aldosterone causes hypertension. It can cause hypokalemia, metabolic alkalosis. Thinking about what it's due to, right? So it can be due to a primary problem in the gland, right? So you have hyperplasia or an adenoma and you lose this aldosterone. Or it can be due to a secondary problem, which is outside of the gland, right? So your renin is increased, which causes angiotensin and aldosterone to be increased, right? So what causes increased renin, right? Usually, especially sustained increased renin, is going to be lack of blood flow to the kidney, right? So that is going to be renal artery stenosis, fibromuscular dysplasia, any renin secreting tumors are going to be the classic ones that you think about. If you think somebody has aldosterone excess, right? You're like, oh, their blood pressure's hard to control. I tried a diuretic and then like their potassium tanked. Let me screen for this. Either one of these, your initial screening test is going to be the aldo and the renin, right? You're going to be getting a serum aldo and a serum renin, and you are going to be looking at that ratio. So in secondary causes, your renin is high and your aldo is high. In primary causes, right, a problem in the gland, your aldo is disproportionately elevated to your renin in a ratio of 20-1 with an aldo more than 10. Right? So aldo needs to be more than 10 and your ratio more than 20-1. So if this is the case, right, your next step is going to be, right, so you've biochemically confirmed Conn syndrome, right? You have evidence of increased aldosterone secretion. So now you need to localize an image, right? You can further confirm with a salt loading test, right? So you give normal saline, you give high salt, and then you see that the aldo doesn't go down. That confirms biochemical excess. And then in terms of localization, depending on the source, this is going to be a little bit different. So I don't think they would necessarily ask you each individual step. But you are going to be doing a CT or MRI of the adrenals, looking for an adenoma. Even if you see an adenoma, right, it could be a incidentaloma and really non-functional. So some sources say that you still need to do adrenal vein sampling on both sides, even if you see an adenoma, just to make sure that it's not hyperplasia. I don't think they would get that nitpicky to give you a CT showing an adenoma and then making you pick to do adrenal vein sampling. They're going to give you probably one or the other, or they're going to give you the results. So if you had an adenoma, what do you do? Right? You see an adenoma on imaging, you sample the veins and it's all coming from one side, you take it out, right? You don't see an adenoma, vein sampling shows it's coming from both sides, what do you do? Medically treat, right? You don't want to take out both your adrenal glands, then they're going to be adrenally insufficient forever. That would suck. So then you have to just suppress. So you would use an aldosterone antagonist to suppress, right? Makes sense? Cushing's syndrome, right? So this is going to be your classic appearance of Cushing's. Cushing's syndrome, like we talked about before, you are going to screen, and if it's the first screening test is positive, you're going to screen again. Your 3 screening tests for Cushing's are, actually, let's pause that and switch to these questions first. Right, so you guys filled these out. It's in your book. This is hyperaldo, so we said hypertension, hypokalemia, metabolic alkalosis. Your biochemical screening test is going to be the aldo-renin ratio with the confirmation with the salt load. Primary is when your ratio is greater than 20 with an aldo more than 10. All right, we talked about the confirmatory test of the salt load. You're going to localize with CT, adrenal, and vein sampling. And you are going to treat with either surgery or medical therapy. Yep. So looking at this chart, for Conn's syndrome, you'd expect the blood pressure to be high. You'd expect the potassium to be, you'd expect the aldo to be, all right, give 2 arrows up for that one. Renin to be low. For a reninoma, the blood pressure would be high, potassium would be low, aldo would be 2 arrows up, renin would be high, 2 arrows up. Hyporeninemic, hypoaldosteronism. Some may call this a type 4 RTA. Your blood pressure would be low, your potassium would be high, your aldo would be low, and your renin would be low. So patient has suspected cons, the ratio is more than 20-1, you confirmed it with the test, we're going to talk about the next step. All right, you're going to do imaging. This autosomal dominant condition looks similar to Conn syndrome. There's hypertension, possibly hypokalemia, metabolic alkalosis, but when you check the labs, you're like, this is really weird and not what I was expecting, right? You have a low renin and a low aldosterone and a low urinary excretion of aldosterone. So what do you think this is? Littles, right? So I think Lozama briefly dabbled in this. So it is a gain of function of sodium channels. So put this in the same symptom category as Conn syndrome, but just know that your ratio is going to be very different, right? So if you get an unexpectedly low aldo when you're looking at that ratio, think of littles. The other thing to think of is also a lot of licorice ingestion. Most common cause of Cushing's, iatrogenic, again, right? Us giving somebody steroids. On physical exam, a patient looks Cushingoid. What's going to be your next step? You're going to screen, right? So here are suspicions for Cushing's syndrome. The usual symptoms, right? Buffalo hump, diabetes, abdominal striae. What can cause Cushing's syndrome, right? We've already talked about a pituitary adenoma. What else can cause Cushing's syndrome?
Adrenal adenoma.
An adrenal adenoma.
Paraneoplastic. Small cell.
Small cell causing ectopic ACTH. We talked about giving somebody steroids, right? They're on prednisone. All right, and then hyperplasia. So you want to screen. You have 3 options to screen for biochemical evidence of Cushing's. Our 3 options again are 24-hour urine cortisol, low dose dexamethasone suppression test, and the 11 p.m. salivary gland cortisol. So if you screen and the test is negative, you tell them, this is not Cushing's, let's try some weight loss, or things like that.
What's the easiest to get here?
I think you can get any of them. Even you can do these as an outpatient, right? So they can go to Quest and pick up a bucket and keep their urine on ice for 24 hours and submit it. That's kind of more cumbersome for them, but it's the best test. It has the least false positives. The low dose Dexamethasone suppression test is pretty user-friendly, right? Because you can give them a dose of 1 milligram at 11 p.m. and then just check a cortisol at 8, right? So it's kind of quicker and less cumbersome for the patient, but the 24-hour urine-free cortisol has the least false positives. So you screen, and you screen twice, and they're both positive. What is your next test to localize? ACTH, right? That will tell you if it is coming from the adrenal gland, in which your ACTH would be low, right? Because your adrenal gland is already making so much cortisol. That cortisol goes back to the pituitary, and the pituitary says, oh, okay, I can calm down, and then you lose that ACTH. So if your ACTH is low, your etiology is in the adrenal gland, you are going to image with CT, and your treatment is going to be, right, so looking back at this chart, we're here, CT, and we're looking for adenoma or carcinoma. For carcinomas, you are going to have other clues, right? They're going to have refractory hypokalemia. They're going to have more issues with hirsutism. So it's going to look a little slightly different. But your treatment's going to be, say it's an adrenal adenoma, surgery. You're going to resect the gland. What do you have to do after you resect the gland? Steroids, right? Because you got rid of their sole source of production of cortisol in their whole body. Their pituitary gland has been in snooze mode. And so you need to do some steroids until their pituitary gland can kick back in. And the rest of their adrenal gland that has not seen any ACTH can kick back in. Does that make sense? So if your ACTH is high, that could be due to ectopic ACTH. It could be due to pituitary disease. This is different from a paraneoplastic syndrome of parathyroid hormone. Right? So with parathyroid hormone, you have PTH or you have PTH-RP. They're different. Whereas with ACTH, it's the same ACTH that you're measuring. So it's going to be high. You could do a high-dose dexamethasone suppression test next, or you could go really based on odds in the clinical picture, right? Most likely it's going to be in the pituitary unless they have a significant smoking history, weight loss, cachexia, in addition to these other Cushing's features, right? But if you did the high-dose dexamethasone suppression test, right, to just further prepare for whether you should do an MRI of the pituitary or a CT of the chest, what is going to suppress on the high-dose dexamethasone suppression test? A teeny tiny pituitary adenoma or small cell horrible lung cancer with a paraneoplastic syndrome, right? The teeny tiny pituitary adenoma is the one that's going to suppress. So if it doesn't suppress, again, you're looking ectopic source, with small cell lung cancer being the most common. If it does suppress, again, that guides you to the pituitary. You're going to image with an MRI pituitary, and how are you going to treat? Surgery. Because pituitary adenomas that are functional or non-functional with mass effect all get treated with surgery except prolactinomas. A patient that has a history of RA, previously treated with steroids, comes in with fatigue, nausea, abdominal pain. On exam, they are Cushingoid, and their blood pressure is a little on the lower side. You have a screening cortisol, and you checked an ACTH, which is low. What is your next step? Treat, right? Give them steroids for a central adrenal insufficiency, right? And do a slow taper. So these are different causes of Cushing's syndrome. So with a pituitary adenoma, what would you expect your urine cortisol to be? High. What would you expect your, actually let's do ACTH next. What would you expect the ACTH to be? High. What would you expect the DHEA to be? High. Right? Because remember, ACTH is going to affect both cortisol and DHEA. So if your cortisol excess is coming from the pituitary gland and coming from the ACTH, your DHEA will also be high and you'll have hirsutism. Treatment we talked about is surgery. Somebody has ectopic ACTH, the urine-free cortisol is going to be 2 arrows up high. Your ACTH is going to be
2 arrows high.
3 arrows high. Your DHEA is going to be
Down. Normal? Still be up. Oh, it's still gonna be high.
high, right? Your ACTH, we just said ACTH high equals DHEA high.
Are we going out of order?
Are we going out of order? We're on ectopic ACTH.
Yeah.
Oh yeah. I'm going cortisol, then ACTH, then back to DHEA. Okay, so with ectopic ACTH, right? So with pituitary adenoma, with Cushing syndrome, your cortisol and your urine cortisol, right? Your 24-hour free urine cortisol is going to be high, 1 arrow. Your ACTH, because it's coming from the pituitary gland, will be 1 arrow up high. The DHEA is also stimulated by ACTH, so it's going to be 1 arrow up high, and the treatment is going to be surgical resection, transsphenoidal pituitary resection. So going to ectopic ACTH, your cortisol and urine-free cortisol is going to be 2 arrows up high, right? Very high. Jumping to the ACTH, just because in my brain I have to think about that first, right? This tells us we do have Cushing's, right? This tells us where it's from, right? So I expect from ectopic ACTH, my ACTH is going to be 3 arrows up high, and because my ACTH is high, my DHEA is also going to be high. The treatment for an ectopic ACTH is figuring out where it's coming from and treating the underlying cause, right? If it's small cell lung cancer, it is not going to be surgery. It's going to be chemo, radiation. So you have Cushing syndrome from an adrenal adenoma, okay? Your cortisol and urine cortisol is going to be 1 arrow up. Your ACTH is going to be low, right? You do not need ACTH because your adrenal gland's doing it. Your DHEA is going to be low. You do not need it. Well, you didn't have ACTH, so you do not have the DHEA. Adrenal carcinomas. Urine cortisol, high. ACTH, low. DHEA, 2 arrows up. So the DHEA is often a marker of adrenal carcinoma. So when you have cancer, and these are usually pretty horrible ones that aren't diagnosed pretty quickly, you have really horrible issues with hypokalemia, horrible issues with hirsutism, right? So when you see hirsutism and when you see virilization, right? Male pattern balding, deepening of the voice, clitoromegaly, hirsutism, you need to be thinking about, in this lady, there's either a lot of DHEA or there's a lot of testosterone, right? So you need to be thinking about, is this an adrenal carcinoma or is this an ovarian tumor? And so the DHEA versus testosterone will also kind of help you narrow it down. exogenous steroids, the urine cortisol and cortisol is going to be lower, the ACTH is going to be low, the DHEA is going to be low, and you should wean their steroids. There's a patient with symptoms of Cushing syndrome. The urine cortisol is elevated. The ACTH is 50, which is on the upper limit of normal. A high dose dexamethasone suppression test was done, and the ACTH went down to 5, and the cortisol went down to 5. What is the next step? MRI of the pituitary. Okay. So DHEA excess, right, which is this bucket here. You are going to see this most often related to increased ACTH activity, right? So somebody with Cushing's from a central source. But you can also see this with an adrenal carcinoma, and then very rarely congenital adrenal hyperplasia that you would treat with steroids. I don't necessarily think that will be on your test. But keep it in your differential if you see a lady with hirsutism, amenorrhea, and also some kind of hypotension type behavior. FIOs, right? So kind of our last one in adrenal gland excess. Remember the familial associations. So men 1 is what? Right, so I always remember pitparpan. Pitparpan, pitparpan. Everybody say it with me. Pitparpan, pitparpan, pitparpan. Because if you remember the 3 P's, you could get confused because FIO is also in these men syndromes, and then that's confusing. So just remember pitparpan. So pituitary is pituitary adenoma, usually a prolactinoma. Parathyroid, right? Pitparpan, pituitary, parathyroid, right? So primary hyperparathyroidism. Pancreas, right? Like an insulinoma, VIPoma. So men 2 is what? A-E. Medullary. FIO. And then what's the unique ones? Primary hyperparathyroid, mucosal neuromas, right? This is also in your packet, maybe on the next page. Maybe not. Number 82. Number 82. So pituitary adenoma is number 82 on your question sheet. So pituitary adenoma goes with men 1. Parathyroid hyperplasia goes with 1 and 2A. Medullary cancer, 2A, 2B. Pancreatic islet cell tumors, right? It's with pitparpan. FIOs, 2A, 2B. and then the neuromas and marfanoid body habitus. It's 2B. Okay. So how would you diagnose a PHIO? What's the first step in endocrinology? Huh? Right? Document biochemical evidence of the PHIO, right? So they will give you questions on the test. Do you want to do a CT adrenal? Do you want to do these metanephrines? Do you want to do a this thing? MIBG nuke med scan, right? Your answer is I'm going to document that this PHIO is true via blood work first, and then I will find it, right? So you are going to screen with either urine or plasma metanephrines. Plasma metanephrines are very helpful when they are negative in urine. Probably, yes. Yes.
You're not wrong.
If it's negative, it's helpful to rule it out, right? If it's positive, you are just checking their metanephrines at a single moment in time. Maybe they don't like blood draws. Maybe they're really nervous. Maybe they just walked in from the parking garage. Maybe they're scared. You don't know. So it's most helpful if they're negative or if they're super sky high on that draw. Otherwise, you need to then do further testing with the urine metanephrines. Now that you have diagnosed biochemical evidence of the PHIO, you're going to do a imaging, right? CT or MRI, and you find it. There's my PHIO. You then do what? Pre-treat with alpha blockade. I don't think they would make you pick between the short-acting or the long-acting because there's advantages to both, right? The phenoxybenzamine is really nice. It's long-acting. But then when you take out the tumor and they are no longer suffering from it, they can have some hypotension after. They do like to ask about intraoperative therapy of their hypertension because you are in the OR during the time of the resection. And you are going to say, I would like nitroprusside for this intraoperative hypertension from the PHIO. Okay? Let's see. So a patient has a 7-centimeter adrenal incidentaloma on their CAT scan. What is your next step? Plasma metanephrines. Right? So when you see this incidental adrenal adenoma, you need to think of two things. Could this be functional? Could this be malignant? Right? Who gets, right, these are all of the different excess hormones that you could get from this adrenal adenoma. Who would you screen for hyperaldo, for cons? If they're hypertensive. Who would you screen for Cushing's? Everyone. Every adrenal incidentaloma gets screening for Cushing's because you could have a subclinical Cushing's picture. Who would get screening with the DHEA? Virilization.
What about men? Do you just, do all men get screened?
No.
Only burly men.
Burly men. Definitely burly men. Usually if it's going to be an adrenal carcinoma causing this, you're also going to have Cushing's anyway. So technically you'd pick up some of that with your Cushing's workup. Who's going to get screened for PHIO? Everyone. So when you see this incidentaloma, you are going to put in their discharge paperwork. We found this incidentaloma. Please follow up with your PCP to get screened for 2 conditions, Cushing's and a PHIO. The size criteria that you would say let's have you also follow up with surgery because this is getting a little bit too large for my comfort. 4 centimeters. If it's non-functional and less than 4 centimeters, then you can kind of just follow it. There's not set guidelines on how often you would do CTs and the functional lab work, so I don't think they would ask you 6 months versus a year. A patient is found to have a FEO after workup for palpitations, and hypertension reveals increased plasma and urine metanephrines. The CT shows an adrenal adenoma. What is your next step in management?
Retreat and then surgery.
Pre-treat with what class? Alpha blocker. The class of medications that interfere with 24-hour urine metanephrine and catecholamine testing for FEOs. Vasopressors.
I mean, you probably shouldn't be tested for feelings.
I imagine that those medications would interfere, but I agree, I'm not sure if you would be testing for that while they are on those medications.
If you're on meth.
Probably. I was going for TCAs. TCA. So next we're not going to really talk too much about a low aldo state, but just keep in mind that that is kind of the classic picture of your type 4 RTAs, your diabetics who have some metabolic acidosis and a little bit of hyperkalemia. So next we're going to just finish up with adrenal insufficiency and fill this out. So in primary adrenal insufficiency, the problem is in your adrenal gland. So you lose both aldosterone and cortisol, right? So that's why you have the hyperkalemia and hypotension more so than over here with secondary, because your aldo is still fine. Because these are down, you get feedback to the pituitary that says, give me more ACTH, and that can't stimulate this, but that comes here and also gets cleaved with MSH, and that's why you get the hyperpigmentation. Secondary adrenal insufficiency, the problem is in the pituitary, right? So your pituitary shut down, so you lose the ACTH, so you lose cortisol and then DHEA. Losing the DHEA is why you have that loss of groin and axillary hair. Does that make sense? So those are kind of the differences and symptoms between the both. So for primary, remember hyperpigmentation, hyperkalemia, more profound hypotension over here, and then the unique symptom over here is loss of axillary and groin hair. The diagnosis, right, is going to be the initial screen for both, cosintropin stim test, or if you have somebody who is in shock already and you demonstrate a cortisol level that's very low, 2, 1, that's enough for the diagnosis. Your next test is going to be the ACTH, right, to help you confirm, right? Usually you can tell based on their labs and their exam, but the ACTH helps confirm where it's coming from. The treatment for primary adrenal insufficiency is going to be hydrocortisone and fludrocortisone, right? So you have to give both. Whereas the treatment for secondary adrenal insufficiency, when the problem's in the pituitary, it's just the hydrocortisone. So patients being treated for infection, they're clinically improving, their labs are improving, their albumin's 2.5, you checked a cortisol level, and it is 15. What do you think about that cortisol level? So if the albumin is lower, then your kind of threshold for the cortisol is going to be more around 12. Kind of like your anion gap. Just think of it like your anion gap. So if the albumin is low, right? If the albumin is low, less than 2.5, and their cortisol is higher than 12, it is most likely not adrenal insufficiency. All right, whereas with everybody else, we'd say probably around 18.
So the lower the albumin, the lower you expect your cortisol to be physiologically.
Right.
So you have to.
So you would say this 15 is pretty good and pretty close to 18 on his own, right? Even without a stim test because he's septic, right? So you're saying he's mounting a pretty good response, and if his albumin was higher, then this cortisol would be even higher, and he'd probably be close to the range that I think of as normal anyway. A patient with sarcoid presents with dry skin, constipation, amenorrhea, and fatigue. Electrolytes are normal. A baseline cortisol is 5. You give cosentropin and it rises to 11. The ACTH is 12, which is on the lower end. FSH and LH are low. TSH is low normal. T4 is low. What do they have? Panhypopit, probably from neurosarcoid. How do you treat their hypopit? Right, so you're going to replace the steroids. You're going to give levothyroxine.
And testosterone.
And testosterone. You have a patient that is hypotensive and you are concerned about mixed edema coma from severe hypothyroidism, right? So maybe they have some edema, they have delayed relaxation of their deep tendon reflexes, they're bradycardic, hypotensive. How do you treat that? Steroids is going to be your first treatment. Your second treatment is going to be levothyroxine, right? So why do we give steroids in mixed edema coma? How?
I didn't figure it out.
So how do you get adrenal insufficiency with hypothyroidism? Central, right? Panhypopit, right? So if they have hypopit, they could have hypothyroidism and a central adrenal insufficiency at the same time. Or they could be an autoimmune person who on the test they'll tell you has vitiligo or maybe also type 1 diabetes or maybe celiac or Hashimoto's. And you need to think, does this person have Hashimoto's and Addison's? Because oftentimes these autoimmune patients will have more than one glandular problem. We call that polyglandular autoimmune syndrome. Okay, that is it for today. We will finish endocrine tomorrow.